All right. Well, welcome back. It's Thursday again for the recording. I'm doing this ahead of time because most of the defenders that we aspire to be more like and to learn from are all gathering right now in Dallas, Texas. And I'll be heading out there on Thursday to give my talk on Friday afternoon. So I just wanted to pre-record this for you all and just kind of walk you through what I think is going to be some exciting stuff that'll be presented at the Society of Benign Prostate Disease, so the SoBPD. And before we do that, let's kind of just go through, obviously, our morning tea quote. Some mornings you have to remind yourself that you got through yesterday and you will get through today too. Great quote. As always, we thank and express our gratitude to the urologist village that it takes all of us to be able to accelerate the guidelines into a new pathway for the future. The nurses, nurse practitioners, the MAs, the administrators, the C-suite executives, and the healthcare industry reps. And as always, we are grateful that the Man vs. Prostate tribe continues to grow in strength and breadth and depth from the Americas to the Italian Brigade led by Luca Cindolo and Scandinavian Brigade and the South American Brigade as we extend all the way out to Australia and to Asia. As always, we celebrate the defenders of the future, especially grateful for now Clara Elaine Glazer from Denmark, who has joined the tribe and will be a defender of the future. And as always, we understand our role as Man vs. Prostate Tribe, that we are working in parallel with the academics as they continue to push forward and advance the evidence-based medicine. We are just presenting a voice for the patient-centered medicine that is coming from the community. And together, we can help our patients live the best version of their lives, chemical-free and catheter-free. As always, we believe in our triple Ps, to prioritize the preservation of bladder health, to put an end to the polypharmacy epidemic, and to prevent late-stage BPH BPO. As always, we're so grateful for defender Amanda Chung, who reminds us with her electron microscopy about the death and destruction that happens when we leave benign prostatic obstruction untreated. And we can see that cystoscopically because we trust the truth of trabeculations. We understand what cellules and diverticuli all mean, that is a detruser under duress, as defender Sonny Schellen reminds us. And as always, defender Rohrburn has reminded us about the window of curability. How do we treat the right prostate for the right patient with the right technology at the right time within the window of curability? This is a very important distinction. We are not a proponent of earlier intervention, but the more timely intervention at the right time. Because in fact, we now have a shared decision-making process version 3.0, which involves not just the patient and the provider, but also the healthcare system and the all-amazing bladder. As we all work together to create a more evolved BPH BPO care pathway, where we are understanding that medications are just temporizing measures as we consider screening asymptomatic men starting at the age of 50, because we are prioritizing the preservation of bladder health by proper counseling, triaging, and risk stratification of patients by getting bladder health baseline so that we can make the best surgical choice, not just based on size and shape of the prostate, but also based on detruser function. And why do we do that? It's because not only are we trying to treat bothersome symptoms, but also bothersome fears. And what do we fear? We all fear late-stage BPH BPO, stage 3 urgent incontinence, stage 4 acute urinary retention, and stage 5 bladder failure. And before proceeding, as always, we go back in history, and on this day in history, in February 8th, in 1952, in light of His Majesty King Charles and his recent prostate procedure for his BPH BPO, we recognize that Queen Elizabeth II, on this day in 1952, proclaimed her ascension when her father, King George VI, passed. And in 1960, the Hollywood Walk of Fame started construction. In 2020, the U.S. reported the very first American fatality from coronavirus. Just a quick reminder, the European Association of Urology has their national meeting in Paris, France in April. So make sure you go there and sign up. So let's jump into the agenda for the Society of Benign Prostate Disease, or SoBPD, or as we fondly like to think of it, as the Society of Bladder Preservation Defenders. On the first day and the first morning, we have some great topics about the etiology and the pathology and the pathogenesis of BPH BPO, trying to understand the cellular understanding of BPH, whether or not there's a role for ischemia, as well as can lifestyle impact LUTS, as well as other genetic causes. From our perspective, this is much needed research. How do we understand on a histologic level what happens when we go from bladder outlet obstruction to detrusor overactivity, at which point we start to see detrusor underactivity come into the scene, and eventually some men are left just with a failed bladder. We need to understand how that happens with the smooth muscle hypertrophy, smooth muscle hyperplasia, with the extracellular matrix deposition of collagen and elastin. And we do need to remind ourselves that, yes, we can look at lifestyle changes and its impact of LUTS, but at Inverse Prostate, we are big advocates of getting a bladder health baseline, letting accurate data drive appropriate decision-making. For those men who are patients who are at risk, let's get that bladder health baseline with cystoscopy and urodynamics if available. And we need to also understand why some men resolve their overactive bladder detrusor overactivity after they've had deobstructing surgery, and why some men do not. And a lot of that needs to come from the understanding of how ischemia plays a role in the pathogenesis of BPH BPO. Later on that morning, we're going to be learning more about office efficiencies for the BPH BPO care, telehealth, as well as how do we deal with that older man with retention, enlarged prostate, and a history of stroke. What do we do about men who have failed a TURP, as well as other roles in understanding medications like anticholinergics? And from our perspective at the Man vs. Prostate Tribe, yes, operational efficiencies are tremendously important because we have so many men that we need to take care of. We believe that by 2050, each urologist will probably have to take care of more than 1,000 men with moderate to severe lower urinary tract symptoms, all the way from diagnostics to therapeutics. That's a lot of work to be done. So we need to be efficient with our scheduling, understanding the role of anesthetics such as nitrous oxide or laughing gas, as well as the point of care ultrasound. In regards to coding, we need to understand how do we code efficiently so that we can make it economically sustainable for practices and physicians to provide proper diagnostics and therapeutics for BPH BPO. We need to understand that, yes, there is a urologist shortage going on right now with a staffing shortage, and 50% at least of the urologists in America are burnt out. What do we do to help them? We need to understand the role of aging on top of the fact that we have benign prostatic obstruction as well as other comorbidities. How do comorbidities such as stroke and diabetes play a role, and how do we tease that out in the care of our patients with BPH BPO? We also need to understand the role of urodynamics and how important it is in this day and age that we get good, accurate data before and after intervention so that we can manage expectations. We can give predictions of how people will do and also lay out what might be needed for secondary therapies for men who have detrusor underactivity and detrusor overactivity despite deobstruction. There's going to be a great talk on anticholinergics. I think in a perfect world, we can dial in the pre-treatment phase of the BPH BPO care pathway so that we can intervene in a more timely fashion before there's overactive bladder symptoms that are refractory to deobstruction. Then in the afternoon, we'll be looking at the comparison between serial minimally invasive surgical therapies versus the concept of one surgery for one patient in one lifetime. And that's the part that I'll be presenting. because I do believe that for the counterpart perspective, how do we find that sweet spot between the 4 elements of efficiency for the man versus prostate tribe when we look at our care pathway? And for us, that is treatment durability, economic sustainability, a man's vitality, as well as the window of curability. How do we find that sweet spot for every man, for every patient, for every healthcare system, for every bladder? And I think it's important for us, as we talk about on Friday afternoon, about how to deal with big prostates. There's not one correct technology for every urologist. I think it's just a matter of understanding what's best for that patient, for that bladder, for that practice, for that system. Do what you do well and do a lot of them in the right context when it's warranted. Also understanding that we need to let the bladder have the opportunity to weigh in on surgical choice. And then on Friday afternoon, they're going to talk about complications of BPH BPO surgeries. I think that's a great one. We always learn from our complications and oversights. And I think artificial intelligence will be an important talk for us all to learn from. For us, from man versus prostate, it'll be great to see how we can use that to better triage patients, to understand who's at risk, and then also use AI to risk stratify the actual bladders, to understand what type of surgical therapies might be best for each specific situation. In our book, at least, we believe that we should be weighing more invasive technologies, such as invasive surgical therapies and the most invasive surgical therapies, to more maximally deobstruct the prostates in situations where the bladders are severely at risk. So specifically when there is proven evidence of bladder outlet obstruction, as well as detrusor underactivity. And then on Saturday, there's going to be some great talks about more minimally invasive surgical therapies, such as prostatic balloons. For us, I think that's really exciting to see what we have learned from MISTs, such as Optilume, such as Urolift, where we need to understand and appreciate the anterior channel of the prostatic fossa, recognizing that we can achieve good results by understanding how do we maximize that area when that is a contributory factor to the obstruction. And then some great talks about using audio Uroflow apps, Urocuff, urodynamics, and also talks about the guidelines, as well as maintaining and optimizing sexual function. Some just quick topics or quick comments. I think, yeah, we do need to understand the role of both software and hardware with uroflowmetry. They both have their role, and I think we need to understand that better as we move forward. Looking at urodynamics, really, there's 2 components, the cystometrogram and the pressure flow study. Get what you can that is available to you. More importantly, make sure we're getting it before and after therapy, so we can use that to help manage expectations and to help provide prognosis for how our patients will do after a deobstructing procedure, as well as to guide us in what is the best type of surgical category to use for that patient. Is it a LIST? Is it a MIST? Is it an IST? Is it a MOST? In regards to the guidelines, LinkedIn Tribe, you all spoke, and you guys all voted that you believe the European Association of Urology will be the first guidelines to take the plunge and to prioritize the preservation of bladder health as our true north, as our prime directive over just simply the management of lower urinary tract symptoms. In regards to a great talk about how to manage pain for prostatic procedures, I think we're seeing the rise of non-narcotic use, non-steroidals, Tylenol, as well as benzodiazepines. And finally, how do we optimize sexual preservation? I think really important is having that discussion with patients about bladder health and the gravity of optimizing detrusor function and weighing that against the volume of one's ejaculate and fertility preservation, with the education and counseling that there is cryopreservation that can be used for sperm, that we can do post-ejaculate urine to harvest sperm for intrauterine insemination, as well as for IVF. And then finally, in the afternoon, there's going to be some great talks using simulation models from Klaus Rohrburn. I think also a highlight there is to look at bphtool.com, looking at the combat data to make predictions about improvements on with IPSS on medications versus the risk of retention. And there's a quick discussion about PAE, prostate arterial embolization, which is coming of age. How do we understand its role within the category of MIST? And then talking about what are the harms of BPH medications. I think number one from the man versus prostate perspective is, yes, we need to put an end to the polypharmacy epidemic. Let us be clear, we are not anti-medications, but we are pro-data. We are pro-choice. We are pro-diagnostics. And also understanding that medications are temporizing measures. They are not therapeutic measures. BPH BPO is a mechanical problem that deserves a mechanical solution when warranted. Yes, medications play their role, but we need to understand that they are in need of being categorized as temporizing measures. There's a great top on nocturnal polyuria. Yes, let's get those bladder diaries. Let's see if the total voiding volume during the nighttime is more than 33% of the total voided volume. And then at the very end, they're going to be talking about papers that were most important, and hopefully they would be able to recognize Defender Luca Cindolo and the Italian brigade that took the concept of the 5 stages of bladder health that I introduced during the pandemic and really brought that to everyone's awareness through their publication in the Journal of Nature, Prostate Cancer and Prostatic Diseases. And for that, the Man vs. Prostate Tribe is deeply grateful for their efforts. And so with that, that's a quick overview. As always, we'll be coming back to this slide at some point to understand how do we triage to understand who's at risk for bladder death and dysfunction that is in need of a bladder health baseline. For right now, as we draft this together as a living document, it would be those individuals with an IPSS that's equal to or greater than 8, plus a Qmax of less than 15 and or a PVR more than 100 cc's, as well as a history of potentially stage 3 urgent incontinence and a history of stage 4 spontaneous retention. Any of those would be able to be qualifiers to trigger a bladder health baseline by cystoscopy and urodynamics if available. And finally, how do we give voice to the bladder? How do we listen to the bladder and allow it to weigh in to surgical choice? On the left here, you can see that with a bladder health baseline with cystoscopy and cystometrogram pressure flow studies, if available, do we need to consider more technology that are maximally deobstructing when we see evidence of obstruction and detrusor underactivity with the bladder health baseline? As always, we'll end with a wellness quote that true happiness comes from within. Thank you all for being defenders of the detrusor with your cystoscopic swords and your urodynamic shields. And together, let's go save more bladders. So I look forward to seeing you guys on the next week. I'll be at the Society of Benign Prostatic Diseases, and hopefully I can bring you some updates there if the software will be cooperative. So until then, I hope you guys have a great week and be well. All right, take care now. Bye.